Hello, and you are very welcome to this quick summary of just in case anticipatory medications. There are two documents you have at the moment which are both truly excellent. They're the first, the guidance for the management of symptoms in adults in the last days of life, and the COVID-19 symptom management in last days of life guidance. There is a lot of overlap, but I want to talk about the former primarily. Just before we go to that though, in the COVID guidance, there is a bunch of phone numbers there which are very, very useful. We are all more than willing to help wherever you are. Please don't hesitate using them. So, why do we do anticipatory medication planning just in case medicines? Good question, Matt. As we have heard, the similarities in dying far outweigh any of the differences. And dying, by and large, is comfortable and peaceful. It is the process, as you know, of our body shutting down, getting more tired, eating and drinking less, and sleeping more. But we live in the land of the Titanic and learn from our experiences. We don't sail at night and ignore all the warnings. We don't sit on our laurels, and we have backup plans. For the potential is there, and we must be alert to it. Hence, anticipatory medication planning. What are the main symptoms at risk of occurring? Yes, secretions. There is a rather unhelpful wide population which have a degree of secretions, the variance of 12 to 92%, and it's likely due to the various papers' definition of what constitutes secretions. Essentially, as the body shuts down, we get weaker, we have no strength nor desire to clear our throat, and invariably it is more distressing for the family than it is for loved ones, than it is for the patient themselves. Agitation, again, the definition of what constitutes agitation varies, with the one extreme being terminal agitation requiring significant medications, which is rare, to generalized restlessness. I would say 42% seems a reasonable number in which the patients require something to help settle. I would suggest is more on the milder than severe end. And 50% of pain in the last 4 months of life seems reasonable to me. Indeed, again, there is a wide variation in terms of severity, with the severe end sticking in our minds but rare. It is of note there doesn't seem to be figures relating to pain in actively dying patients. I would suggest if you had an achy back before dying, you probably still do when you are dying, and that may require some analgesia, but there is certainly no evidence that pain increases as you die. And nausea and vomiting is tricky because it likely depends on the disease. Likewise, shortness of breath. There are symptoms which need controlled in certain patients, but are certainly not a common thing in the normal dying process. Needless to say, a proportion have it, therefore it needs control. The last dose curse. Yes, I wanted to mention this. The last dose curse. How many people have heard this? The nurse gave me an injection and the patient died 20 minutes later. This is a misunderstanding. There is a perception that the nurse killed or helped the patient off, and even worse, sometimes the family are thankful for this, sometimes not. What do we do about that in terms of our own conscience, in terms of family perception? So the first thing to say is this is a false attribution. The prescribed PRN just in case medication did not cause the death. There is always going to be a last dose. And avoiding patients getting their anticipated medications on fear of this false perception isn't helpful. It will mean that they potentially could suffer various symptoms. I would suggest we can deal with the family's perceptions later, and if you need help with that, we're very, very easy to contact. in terms of dealing with this particular ethical scenario. Anyway, let's talk through our guidance. As stated before, this is the guidance for the management of symptoms at end-of-life care. I think you have it in your packs. It is very easy to work through and covers almost all scenarios. And I want to walk through it with you very, very, very quickly. So, pain, first of all, this is the page which the patient does not have pain, or pain is currently controlled by their medication, but the patient has lost their ability to swallow. So options from left to right. One, at the far left, they've got no analgesia. What to do? Well, it's morphine sulfate, subcuts 2 to 5 milligrams, 2 to 4 hourly PN. Okay, 2. They're already on cocodamol or tramadol. These are milder opioids. And there it instructs how to change to a syringe driver and the PRNs, just in cases. Number 3, you're already on morphine. Therefore, use a conversion table. I'm going to show you that in a second, how to do that. Or 4, when on a patch. And when we're on a patch, we keep that patch going and titrate the syringe driver almost separately, depending on the PRN use. Of note, PRNs are 1/6 of the total 24-hour opioid dose. If the patient has pain, we obviously encourage the use of the correct PRNs. Again, left to right. Number 1, morphine sulfate, 2 to 5 milligrams PRN. This is if they've got no regular analgesia. And a syringe driver, 5 to 10 milligrams every 24 hours. 2, if they are already on morphine, use a conversion table, which is my next slide, and prescribe a syringe driver. Note, you should start a syringe pump 8 hours after the last dose of long-acting opioid, such as MST. And 3, if on a patch, use the PRNs to titrate if on a patch, use the PRNs to titrate the syringe driver separately and keep the patch going is the general advice. And then this is just the conversion table, and this is the conversion chart in the booklet, and it is beyond the specific scope of this lecture, but different opioids have different properties and namely have different purposes in renal dysfunction specifically. For example, oxycodone is considered safer in mild renal dysfunction, eGFR 40-ish say, but alfentanil is the best in severe renal dysfunction. Morphine is better than oxycodone in liver impairment, for example. And these considerations are important and what your GP will be very much aware of. If the patient is actively dying, then we rarely switch opioids, as the distinction between them becomes academic. However, there are instances we should discuss regarding opioid toxicity in which switching the opioid is important, but that's a bit later. Okay, let's move on to nausea and vomiting. Very simple schematic here. If you've got no symptoms on the left, prescribe cyclizine 50 milligrams subcut PRN, or switch the current antiemetic to the syringe driver. If symptomatic, on the right hand column, start it in the syringe driver and titrate. And the doses are here. So first to third line to progress through is having trouble controlling. Also there's the max doses there. Of a odd particular note, everyone has a favourite antiemetic, anti-sickness medication, both the doctors, nurses and patients. If it's working for the patient, I would generally advise staying with the one which is working. Of some very specific notes, ondansetron is often the least favourite for palliative care doctors, as it causes a lot of constipation and thus the bowels need to be monitored and laxatives used quite often. And cyclizine is unusual in the syringe driver. That is one of the medications which only mixes with water and doesn't mix with saline, and therefore that has to be taken into account. Okay, what about breathlessness? Well, it doesn't seem common knowledge, but the most evidence-based method of controlling the symptom of dyspnea, shortness of breath, is low-dose morphine, Oromorph, 1 to 2 milligrams orally, 2 to 5 milligrams orally, or 1 to 2 milligrams of morphine sulfate subcut as a PRN. Or if they're already on an opioid, which is the column to the right, for a syringe driver of 5 milligrams over 24 hours. It really works. The opioids change your perception of shortness of breath, as well as it helps pain, but it's not just for pain. Obviously, this may have already been done in a syringe driver. They may already be on morphine, and therefore, if the patient's also in pain. However, you can therefore instruct the patient and the nurses and the team that they can get PRNs of morphine sulfate when shortness of breath, not just when there is pain also. So it's an education thing. Also worth mentioning, obvious things are obvious. Please give oxygen, and if there's anxiety or panic attacks, benzodiazepines are the way to go, with midazolam being the subcut option and lorazepam being the sublingual. The blue lorazepam can go sublingually or oral option, and they just lower down, and again escalating with that into a syringe driver. Now that leads us on nicely to anxiety, delirium and agitation. I would say it is anxiety, agitation and non-reversible delirium in end-of-life care, because if it's delirium caused by infection or something else like hypercalcemia, then the GP needs to think of reversible things, and that's a separate lecture about that. Anyway, anticipated prescribing is a small amount of midazolam, 2 to 5 milligrams subcut, 2 to 4 hourly, if there's no symptoms, and if there's the symptoms, we stick up a syringe driver, normally starting with midazolam 5 to 10 milligrams, progressing to the addition of levomepromazine or haloperidol 10, levo 10 to 15, or haloperidol 0.5 to 1 milligram subcut, and that normally settles nearly 99% of the agitations. Sorry, just closing the curtain so you can, so I'm not in a beam of light. Right, noisy respiratory secretions. If we have secretions, we prescribe the just in case anticipatory medications are as before, and if they're symptomatic, we put it in a syringe driver. So glycopyrronium is the medication of choice and can be progressed to butyrbromide if that's not wholly effective. These medications dry out the mouth and the rest of the secretions, and thus the most important consideration in end-of-life care is to do mouth care, normally with a gel such as biotin gel to look after that mouth. A dry mouth is horrible if you can't get it moist or drink anyway, and it sometimes contributes to nausea, so it's important to do this in all dying patients, but especially in those which are having things to help dry out secretions. It may also not completely stop the secretions. As I said earlier, that secretions are due to the buildup of and breathing through the liquid there, and sometimes once it's there, it's very hard to get rid of. Anyway, and reassurance is what's needed to the family. Anyway, follow the proformas there, and you can't go too wrong. Anyway, I hope that is a very quick whiz through the symptom control booklet is useful. Please keep it close at hand. It's a very useful companion to be ready just in case, and ask for people, GPs, nurses, other doctors to plan ahead. Not because these problems are going to occur, but because they could, and it would be foolish not to think about them. Be the boy or girl scout, be prepared. None of these symptoms in the first instance should require admission to hospital or hospice. However, if they don't come under control, of course, appropriate escalation is required. I hope you've enjoyed that. We can talk about more things in detail. Thank you.